Thank you for having me here today. I'm actually based in the academic department, so just around the corner from Main Theatres over in QMC. As Rob said, I've been working around there for about 17 years now, but my background is ITU nursing, so I come from a very different, so my ideas of double checking and things like that is quite different to the medical professions. That's not to say that I think it's great. So today I just want to give sort of like an overview of drug errors in anaesthesia, but it's more of a national sort of like regional level rather than actually down to NUH actual figures. What causes error and things for you to think about in your own practice, maybe as a takeaway message. So we'll go through some of the studies that we've done as well, but not in huge amount of details, but just how we found things as we've gone along. I'm actually a qualitative researcher as well, so you'll find that most of my research will be around sort of like barriers, facilitators, and people's expectations, not so much the quantitative figures. So this is the definition from the NRLS, the National Reporting and Learning System. So an error, medication error, is any incident where there has been an error in the process of prescribing, dispensing, preparing, administering, monitoring or providing medicines advice, regardless of whether any harm occurred or was possible. So this is what they're expecting us to report back on. So not just the things that cause the error, but also the near misses. So an estimated 237 million medication errors occur in England every year, 66 million of which are clinically significant. The third WHO Global Patient Safety Challenge, so medication without harm, has set a global challenge which aims to reduce severe avoidable medication-related incidents by 50% globally by 2022. So we've got quite a way to go on some of this. At the moment, and it's still been going on since around about 2000, I mean, we did a double checking study for the MPSA and the Royal College back in 2008. And working with Alan Merry and his team over in New Zealand, we also did a big study in 2009 looking at barcoding and double checking that way. And at the time, error rates in anaesthesia was 1 in every 133 anaesthetics. That number's still banded around today. So we don't seem to, there's been no new evidence to say that we've reduced error per anaesthetic in that time. They've just started to do mathematical modelling around error. So putting numbers into the computer to actually decide how frequent errors will occur. And the mathematical, there's a paper published in 2019, well, this year, earlier in the year. I've put a list of reading at the end of my slides, but that's because I'm educational, so that's how I work. But it's worth going to have a read. And they do say that a drug error will occur in around 10% of operations that are up, around about 12 hours in length. So your long operations, you're more likely to get drug errors occurring. One to unpick, though, and it's the first one it's been done in mathematical modelling. But it's come from Professor Pandit, so we do expect that to be good because he's does a lot of work within error, and he was SNAP 5, wasn't he? In intensive care practice, the incidence of adverse drug events is reported to be 130 errors per 1,000 patient days. So this is national figures, but this is still quite high. And adverse drug events are known to occur more frequently during the maintenance phase in anaesthesia, at around 42%, compared with either induction at 28% or beginning of surgery around about 17%. So I think we mostly expect errors to occur during induction, and it's actually through the maintenance phase when we're more likely to be distracted. So wrong medication was the most common type of drug error at 48%, occurring perioperatively, followed by overdose, incorrect route administration, underdosing and omission. And sometimes our omissions don't get recorded. And as I move on to the next slide, these are the reported incidents from the NRLS nationally across all specialities for this year from January to March. As you can see, there's medication with 52,000 errors. And I would like to point out as well, with the work that we're doing with Rob, medical devices, that's actually coming up as well. But if we look at the anaesthetic speciality related incidents, in the same period, we've had 1,888. The medical device and equipment errors are actually 1,300. So you might find that some of the drug errors are being reported as device errors and not as the drug medication errors as well. And it's one to unpick. But as we all know, errors are underreported because we don't do it. And this is the error iceberg. So only reported errors tend to be errors that cause actual harm are the most reported. As you look along, errors identified with potential to cause harm or near misses, they're relatively reported, but there is the understanding that a lot get missed and don't get reported through. Errors identified but considered insignificant, even more are likely to be unreported. Potential errors are not, there's only a little tiny bit at the top that's actually reported, and unnoticed actual errors just tend to slip. In a couple of the studies we've done when we've been looking at error within anaesthesia through the observations, the closer the drug got to being administered to the patient was the more likely it actually got reported. So the ones where you'd pull out the wrong box from your drug cupboard and realise it was the wrong one before it went into a syringe, that just went back in. But you could say that was an error because the boxes were in the wrong place, or it was the boxes look alike. So some of these, reporting can actually help improve the actual systems in place. And it's not necessarily what you need to do as an individual, but how your setup is within the anaesthetic rooms and the boxes coming in from the manufacturers. So there's different causes of error, so we'll just touch on these. So there's person-centred approach and system-centred approach. So if we look at the person-centred approach first, the causes of error tend to be put down to forgetfulness, inattention, negligence, poor motivation, recklessness, distraction and carelessness. And the way the system reacts to this is through poster campaigns. So, Stop the Block is one of the ones that came out from that, really. That's more almost, it's supposed to be a system way of working, but it can actually be blaming the anaesthetist for getting the wrong block. Procedural review, disciplinary action, so you're blaming the individual, threat of litigation, retraining, naming, blaming and shaming. So in this system, the individual is responsible for causing the error. There's nothing actually looking at what they're working within. The focus is very much on the sharp end, so the doctors, the nurses, the pharmacists working in that area, and it's corrective measures that are aimed at the individual and not at what they're working within. The systems approach is very much about error-provoking conditions within the workplace, so time, pressure, understaffing, adequate equipment, fatigue, inexperience, and your weaknesses and your defences, such as your unworkable procedures, design inefficiencies or equipment failure. And the way that we react to this error is generalising it rather than isolated. So you're looking at it more as sort of like a whole rather than it's actually a one-off and it's that person's fault. It's very much looking at the system to see if it's happening anywhere else. As a system is reviewed to limit the incidence of error, so and also the system is reviewed so that if an error occurs, its damaging effects are minimised. So the basic presumption is that everybody is fallible and errors should be anticipated even in the best organisations. Errors are created and triggered by elements within the system. So it could be the organisation's attitude towards safety as a whole, the culture it promotes, or the position management takes to actually reduce the risk. So it's how, how many devices have you got running in your theatres at the moment? How many different types of pumps? The more pumps, different types of pumps are out there, the more likely that it's going to be causing an error because we've got to train everybody up into different systems. All potential hazards and technologies should possess some sort of built-in barrier or safeguard. A lot of our work we get referred back to like nuclear power plants and the airline industry. I don't think that's perhaps the way to go, but it's one of those things that you have to think about reporting and how the system can be made better. Central focus should be on the conditions that trigger the error, not on who made the error. So from that, you'll have active failures and latent conditions. Now, these are some of the terms that are bandied around within human factors, but they do apply to how we look at the drug errors as well. So active failures are slips, lapses, mistakes and violations. So slips are a result from failure to execute an action, whether or not the plan behind it was adequate to reach its objective. So in anaesthesia, you might say giving a muscle relaxant prior to giving your induction agent, turning off the oxygen instead of the nitrous oxide, or you could actually attempt to ventilate a patient with the circuit by squeezing the bag when you haven't actually flicked around your switch to take it off the ventilator. They're all classed as slips. Your lapses involve memory failure and may only be apparent to the person who experiences them. So failure to give you a prophylactic antibiotic even though you've got it out ready and it's on your anaesthetic machine. Placing the non-invasive BP cuff on the patient, taking a stat reading, and then forgetting to switch it onto cycle. So you've got a reading up there, but it's been there a while. You could also say that very long time ago, you used to be able to monitor different areas, especially within ITU. So we could pick up different beds on the market. And it could be that you've got the wrong bed up and you're looking at a completely different patient, or a wrong theatre up and you're looking at, it doesn't happen now, but it did do in the past. So mistakes. The individual is aware of the problem and begins to use rules or knowledge to solve them. A mistake occurs when the necessary knowledge or rules to solve the problem are lacking. So you can have a rule-based mistake, and that's a failure to actually apply or misapply good rules. So you get the wrong one to fix something, or the application of bad rules. So you think you've got a good way of fixing it, but it's not actually the right one. Rules may be the individuals or protocols driven up by external bodies. So it's not just something that you've learnt as you've been going along. And it could be that you've been taught that by somebody in the past, and that's the way you've always done it, but actually it's not the right way to go. Or it could be that it's policies and procedures that are in and they just don't work within the area that you're sitting in, but it's set there for you to actually have to use. You can have knowledge-based mistakes, and these can be considered errors of judgment occurring in on-the-hoof problem solving when all of your pre-packaged ideas are worn out. And this can actually go down to fixation error. So as you know, with Martin Bromley case, with his wife, that was very much a fixation error. And they fixated on trying to get a different tube down rather than actually stepping back and actually looking at what needed to be done. And they fixated on a piece of equipment rather than actually what the patient was looking like. And they didn't get around to ITU quick enough. Even though one of the nursing staff had already booked the bed. It's communication as well that fits in with that. So we've got violations can be described as deliberate breaches of rules or policies. They do not inevitably imply harm or disregard safety. And they stem from considered choices and the deliberate deviations from standard instructions that seem to offer some element of advantage. So in this case, it could be ignoring fasting guidelines for elective surgery, omitting to perform preoperative assessment, getting your ODP to draw up your drugs when you're not in the room. And I know this doesn't happen in NUH, but it has happened in the studies that we've gone along to. It's set out by the colleges that whoever's administering the drug should be the one that draws it up. You can have them in the room and you can check it with them, but if you're outside the room, then that's not supposed to take place. But that would be a violation of practice, and it can be driven by workload. It can be a system error that's making it you start to violate. So if we move on to latent conditions. Latent conditions are always present. They theoretically should be able to identify them before it causes an adverse event. And these are the two types. So they can either be conditions within your workplace, such as time pressure, excess fatigue, staff shortages, lack of experience, inadequate equipment, or it can actually be long-lasting holes or weaknesses in the defences. So you've got untrustworthy alarms and indicators. So you start to ignore them because you don't believe it, but you actually do need to act on it. Unworkable procedures and design and construction deficiencies. So it could be a long time ago, the anaesthetic rooms all used to be different across all theatres. We standardised those over the years so that the drugs are in the same place and all the equipment is in the same place to try and take out any latent conditions that might actually cause error. So latent errors set the scene to make it more likely that an active error will occur. So picking up an incorrect ampule of a drug and administrative is an active error, but if the drug comes in a similar ampule or a similar coloured box as another anaesthetic drug, that's a latent error because that's the system that's likely to cause it, and that's something that could actually be fixed. It increases the likelihood of an error occurring. So we started to talk about the 6 Ps within latent conditions. So if you can just remember the 6 Ps and how it works within your practice, that might be quite useful. So we've got providers, procedures, products, peripherals, patients and policy. So these can all impact on latent conditions. So I've tried to do it so that I've taken it into an anaesthetic perspective. So for providers, it might be the anaesthetic trainees working in a variety of unfamiliar hospitals with a variety of unfamiliar equipment with little or no time for appropriate device-specific training. So our carousel, we move around every 6 months, and it could be that across the different trusts that you work within, you're going to go into different areas where you've got different pumps, you've got different ways of working, different ways of where the drugs are kept. You've got to learn the anaesthetic rooms again, and if you've never been there before, that can take a little bit of time. When I did my ITU course, I went across all of the ITUs across, Derby, City, NUH. I was based at NUH, over at QMC, and we did our drugs differently. So our noradrenaline was drawn up differently into different strengths, which became to the point where I had no idea what I was delivering because we were quite neat over at QMC. Ventilators were completely different at that point. Our pumps were completely different at that point. So it just puts you out of your comfort zone just for a bit while you get to learn it again. And sometimes you don't have that time to actually relearn it, if you've got issues going on. So procedures, your patient arrives late for same day admission, your list starts late, and then there's the pressure to catch up. So you're always on a catch up. It might mean that you're taking your patient round to recovery. At the moment, we know recovery is quite difficult to actually release you to get out of, because there's a backup of handing over, and then you're coming back into your anaesthetic room and your next patient is already there. So you've already got the possibility of distractions while you're drawing up your drugs. So that's a latent condition because that's the system that you're working within at the moment. Products, similarity of drug ampules may lead to drug substitutions, and we were talking about this recently, that depending on what's coming in, drugs can be in foreign languages. We had it where one drug came in and it was in German because that's the only one that we could get. Recently, there's been something coming in Japanese. So it's difficult, you're facing problems straight off by actually having to understand what drugs are in which boxes. And if the drug boxes are looking the same, it's even harder if it's in a foreign language to work it out. So peripherals, so the infusion lines, connectors, pressure devices, filling systems for vaporizers all have the potential to add errors, especially when new equipment appears. We're talking about moving over to different anaesthetic. Are we going on to different anaesthetic machines? Oh yeah. So there's that window of time when you've got to relearn what's going on, and you get used to your systems, and then they all get changed. Say with pumps when they get brought in and new. Patients, not all patients will remember their drug allergies. Many will not remember any of the drugs they take. Not helpful, but it's the way it goes. And there's still sometimes the lag of what's coming from the GPs to the wards, for the wards to be able to tell you what's going to happen when they go through. And we're going into more same-day admissions now, so it's just the way, if the information isn't there for you, then that's a latent condition. It's not your fault, it's just the way things are. And policy. So this is just an example from something. Anaesthetists were banned from taking food and hot drinks into anaesthetic rooms. The impact of tiredness, fatigue and hunger on slips and lapses have been reported in critical incidents. It's the same when you're really, really busy, you might not get out for a break at all, or there's not enough staff to release you during your long shifts. You'll become fatigued. Fatigue is a big thing within the Royal Colleges at the moment. So we're trying to look into that to actually improve working life and ways to actually address that. But it depends on what your local policies are and how things work, could actually just impact on the latent conditions that are around. So I've got a case study just to go through to give you an idea, something to think about. It's something that we use in one of the teaching sessions for an MSc. If I'm telling you to suck eggs, I do apologise, but it's just to think about the latent conditions and the active failures. So, as part of the routine set up for surgery, a member of the anaesthetic team assembled 3 different infusion devices. They were a new member of the team in that operating room, having just started working at the hospital a few weeks before. The other members of the team had been working together for at least 6 months. The new staff member was being very careful when setting up the devices because one of them was a slightly different model than they had used before. Each infusion device administered a different drug that would be used during surgery and had to be programmed. The drugs had different concentrations and each required calculation of the correct dose for that specific patient. The correct doses were programmed into the infusion devices. The anaesthetist was usually present while the infusion devices were being set up and checked them before the patient was brought round to the anaesthetic room. However, on this particular morning, the anaesthetist was running behind from their pre-op assessments. When they arrived in the anaesthetic room, the patient was there already, and the rest of the team were ready to do the WHO checklist. The anaesthetist quickly glanced at the setup and accepted the description of what was in each pump by another member of the anaesthetic team. One of the infusion devices was started at the beginning of surgery. About halfway through the surgery, the patient's blood pressure began to rise. The anaesthetist tried to counteract this by starting one of the other infusion devices that had been set up earlier. They checked the drip chamber in the intravenous tubing and didn't see any drips. They checked the IV tubing and found a closed clamp, which they opened. At this point, the second device started to alarm and signalled an occlusion. The anaesthetist found a closed clamp on this tubing as well, opened it, pressed the restart button, and the device resumed pumping without further difficulty. They returned to the first device they had started and found that there had been a free flow of fluid and medication to the patient, resulting in an overdose. The team responded appropriately and the patient recovered without further incident. That's good. So, in this study, we've got several latent conditions. Multiple infusion devices were used in parallel during the surgery. 3 devices were set up, each requiring many steps. Each step in the assembly presents a possibility for failure that could disrupt the entire system. Each of the 3 different medications had to be programmed into the infusion device with the correct dose for that patient. Possible scheduling problems in theatres may have contributed to the anaesthetist having insufficient time to check the devices before surgery. A new member of the team may have interrupted the normal flow between the team members, especially communication between the anaesthetist and the new member of staff in setting up the devices. And training of new team members may be insufficient since the device was a slightly different model. As a new employee, they may have been hesitant to ask for help or may not know who to ask. So we don't always run with multiple infusion devices, but it's just to think about when you're in your practice about what's going on and how many distractions are going on. And we know that time is a real problem at the moment and patients are arriving in the anaesthetic rooms before they should be. So it's just something to think about. So these are the methods proposed to reduce drug error. So this was based on a systematic review that was done in 2004, and all the systematic reviews and all the research that's been done since hasn't really changed. And this is what a lot of our research is actually based on as well, and things that we've done within the anaesthetic department back at QMC, within the academic department. So careful inspection of labels before drug is drawn up or injected. Optimise label legibility and contents on syringes according to agreed standards. Formal organisation of drug drawers and workspace. Second checker for labels before drug is drawn up or administered. Thorough reporting and review of intravenous drug administration errors. Manage drug inventory to focus on minimising the risk of drug error. Avoid similar packaging and presentations of drug where possible. Now, the work that we did in 2008, 2009 was really looking around double checking. So point 4 really, second checker for labels. We did, the first study that we did for the MPSA and the Royal College of Anaesthetists was looking at the feasibility of introducing a double check or an electronic barcoding check. And the second one that we did was working with Professor Mary, so it's an international study, and that was more around the electronic barcoding and seeing if it actually increased workload. So if I move on, this was reported in 2019 within the NRS error reports. So vancomycin 1.5 grams had been prescribed as a perioperative antimicrobial. 2 vancomycin 1 gram ampules were taken out of the box, checked and placed on the countertop. The practitioner left the room to collect the 500ml saline bag, intravenous pump and giving set. On returning, they picked up the ampules, checked them again and drew them up into a 20ml saline in a syringe, discarded 5ml as only 1.5 grams were needed. The ampules and syringe were shown to another practitioner and the remaining 15ml injected into the 500ml bag saline, and this was infused slowly. The patient experienced weakness and respiratory difficulty, and it took some time before it was realised that the ampules were in fact vecuronium ampules. So this was double checked. Personally, as I was saying to Rob, working on to you, the only 2 drug errors I've ever have been double checked. So although we do a lot of work on double checking, there's some issues around it, and it's mainly to do with diffused responsibility. So you'll find that Brian Toft writes a lot around this, and it's very much, if you've got two people double checking a drug, they rely on the other person to check it properly, so that neither of you are checking it properly, and therefore it manages to get through. So this was the double checking process that we used in the MPSA Royal College study. We went out, we had 7 NHS trusts across the UK. We couldn't actually be involved because we were running it. So there was York, Lancaster, Wrexham, Papworth, St Thomas's. I'm going to miss one, hold on. We had 7. There was 2. I know that Papworth and Wrexham both got the electronic barcoding. This was actually the bit for the double checking. The first bit is for preparation of drugs, so the bit on the left. This was a flowchart that was devised with human factors input before it went out. So as you can see, it's quite a long process, and you had to get your second checker to read aloud what was in the box, what was on the drug before it got drawn up, and they had to read aloud. And then you also had a double check for the administration as well. So if you were about to give matrimonial, which is given quite a lot during some operations, you had to double check it all the time. For the barcoding, because this is based on a New Zealand system that most of their drugs were pre-filled already and labelled in pharmacy, that works really well. In the UK, we don't do that. We don't keep a lot of pre-filled syringes. So it was drawn up as normal, and then it had an electronic barcode stuck on it. So we tried to make it as near to perfect as possible, but we could, it's just the way the system ran. What we did find through the observations as we were out there, that at some points halfway along, as you started to draw up a drug, you'd get your second person to read it aloud, and then you start drawing up your second drug while that person's reading out what the first drug is. And so the workarounds already starting to come in even before we'd actually got to the point of getting it into the syringe. So although you might have these great human factors driven checklists and flow charts, we as clinicians will always find a way of working around them to make the process speed up. I did record the time it took for somebody to draw up. It was a general surgery case up in York, and I timed them from the beginning they started doing this process to the end of their just like drugs that they would need for induction and the ones that they might need during their surgery, and it took 15 minutes. So, that's a very, very long time just to get your drugs drawn up for one patient, and it has a complete knock-on effect to the rest of your list. And then you've got to find somebody to actually check your drug while you're in theatre. And your ODP is normally off wondering, getting equipment that might be missing. So to actually find somebody to check your drug before you give it manually, it was really, really hard. And a lot of the time they ended up asking the scrub nurses because they were the ones that were still there and possibly free, but possibly not. So again, you're putting distractions into the surgical team then. So not great. We did work on, so with the electronic barcoding, that was a lot better, but we were worried that it'd add on to workload. It was something that we weren't used to. So what would happen with that is that before you would give a drug, you would scan it on the system and then you could give it. It would prompt you if you hadn't given your antibiotic, but it also write your anaesthetic record for you. So there was some payoff with that. Papworth had it put through all of their theatres, and as far as I'm aware, they still use it. But it's cardiac. It's very specific on what drugs they will use, so it's easy to get their drugs pre-filled in advance. Going into Wrexham, it was a lot harder. It was within their general surgery and their obs theatres. And having the drugs pre-filled, if you haven't got a manufacturing pharmacy, it's quite hard anyway. Very expensive, and if they were finding the shelf life on their drugs, they were having to chuck a lot away because they weren't using it quickly enough to make it cost effective, have enough done. So when should your incidents be reported? So the MPSA encourages reporting of all patient safety incidents. I would like to say the MPSA and the NRLS is being updated. It's going into a whole new system, so like within the next 12 months. So it'll be interesting to see how that changes, how we report back. The MPSA now sits in NHS Improvement, so it's still there, but it's not called MPSA anymore. So incidents that you've been involved in, incidents that you may have witnessed, incidents that cause no harm or minimal harm, incidents with a more serious outcome, prevented patient safety incidents known as near misses. They base it very much on an airline model to some extent, in that they want the near misses and the no harm, the ones that actually don't make any errors reported. We haven't quite got there yet, but I don't think we'd have the same the airline industry is very much driven around learning from near misses, whereas there's still this blame culture that sits across the NHS, unfortunately, and we haven't moved away from that. So there is a reluctance to report the near misses. So, are you at risk? Factors which increase the risk of drug error: distraction, fatigue, workload. So, distraction, we moved on to work from the double checking study looking into distractions and what actually happens. And one of the things that they had with the Safer Sleep system, which is the electronic barcoding, it was very much about how you set out your drugs. So it was colour-coded. They used drug drawers in New Zealand rather than cupboards like we do. But it was very much set out, and the colour of the tray was very much matched your colour class of your drug, and then it was set out in how you would do your anaesthetic. We recently, in the last 2 years, did a study looking at rainbow trays, which you may have come across within NUH, and that was sort of taken from the tray that came with the Safer Sleep system to try and make it easier to fit into our practice. It does help, but again, it's very much about, keeping things together. It's not the complete solution. It's just one tool that can be used to actually reduce error. So distraction makes it more likely that a wrong drug ampule will end up in the syringe. Distraction makes it more likely that a wrong syringe will be picked up to administer the patient. And distraction makes it more likely the drug will be omitted. We're very busy. We have a lot of throughput within theatres, and we try and keep it to a minimum in the anaesthetic room, but within theatres we have a lot of visitors, we have a lot of people transiting through the areas, and distraction can occur quite easily. What that impact of distraction is on the anaesthetist is still waiting to be seen. NAP5 distraction was one of the main causes of awake, paralysed awake airway. So they say that syringe swaps was the most common cause of paralysis, and distraction was the most common cause of causing that in the first place. The only RCT that's been done looking at drug error was on a ward-based, so it's hard to actually unpick the actual true incidence. So fatigue is a big thing for the college at the moment, and EAA, it's the Associate Anaesthetist now, isn't it, rather than AGBI, but they've put out documents on fatigue. Drug errors are 4 times more likely to occur if you're fatigued. New Zealand survey of anaesthetists reported 86% of respondents had committed a medical error that they attributed to fatigue. And in OBS anaesthesia, the risk of unintentional dural puncture during epidural insertion at night compared with daytime is increased 6-fold. So it does have an impact. Put workload down there. So it's not just necessarily high workload, it can be really low workload. And sometimes when you're really busy, you keep things running. But when there's periods of long inactivity and then you've got to respond, that can be also when the drug errors occur. And then finally, further reading, because I'm an academic, so you can go away and read stuff. But if you've got any questions on it, it's just a brief overview of something.